Hi, my name is Dr. Dan Alyesh. I'm a cardiac electrophysiologist in Denver. We're debuting the ICE Image of the Month on HRS TV. Our goal with the ICE Image of the Month is to take the higher level ICE skills and disseminate them so that other hard rhythm members can learn, and we can kind of expand the use of ICE because it has so much potential and so much potential that is not realized in the average procedure. And we are very happy to have Dr. Mansour Razminia join us for our first episode. Welcome.
Thank you so much, Daniel. Thank you for having me.
Dr. Razminia, do you watch Game of Thrones, or did you?
Of course I did, yes.
Okay, how do you feel about being referred to as the Ice King?
They have called me Ice Daddy, they have called me Ice King. But it is my passion. I really love ice. I really think that it really adds a lot of value to the procedure. It really is something that I want everybody to start using it, so to the extent that it is possibly you can use it for every type of procedure, and make sure that you don't use it for one part of the procedure. When you use it for a procedure, use it for entire procedure from the beginning to the end.
Absolutely. So, the case that Dr. Razminia is going to share with us is that of an LV summit endocardial ablation. And so I wanted to start off with this discussion. First off, a fantastic case. Thank you so much for joining us. But how did you decide to choose this case?
The very reason is that we know that we use ice for many type of procedures during the catheter ablations, and many people, unfortunately, of course, just concentrate using ice for the transeptal puncture, and that's it. Or some people, we started to use it more and more for, let's say, flutter ablation, atrial fibrillation ablation, and so on. But I also wanted to show that how it is important to be able to do it for other type of arrhythmias, such as PVC from LV summit, which is could be very challenging, but at the same time, when you are able to use ice, it shows you that how it become so much more understanding and much easier for you to be able to perform this procedure.
So, I think that, the image that you capture in this procedure is a great image of the summit, and you're imaging the left ventricle from the right atrium, right? And it's a beautiful image, but, as somebody who does a little bit of this himself, what happens when the right atrium, say the septum is thick or the image isn't as clear as this? What are some troubleshooting techniques that you have?
Excellent question. But I think I always suggest that to know few different types to be able to, if you're going to go to downtown and you need to know 2 or 3 roads to go to downtown, let's say. If 1 or 2 are, there is some construction and you go third way. So it is always better to know different ways to be able to look at the same picture. The best one to look for that particular area, this is for LV summit. Of course, if you're going to look, let's say LVOT or papillary muscles for that matter, you better look at them from right ventricular, maybe even apex. But for being able to see that aortic valve and the LV summit exactly where you want to see the catheter and touching that area of the LV summit, that would be the best, of course. And remember, it is like fine tuning a little bit. Remember, it is as if you are in a movie theater and you cannot see the screen. You just come back a little bit to the left, to the right, because somebody's in front of you. Do the same thing with your catheter. Do a little bit fine tuning. Do a little bit right. Do a little bit left. Do a little bit, anterior posterior to be able to do fine tuning. But of course, the closer you go towards the septum, so you have to be a little bit high in the right atrium to be able to get this view of the LV summit. Again, you can do it from the beginning of the right ventricle or RVOT for that matter, but you would be able to see the short axis of the aortic valve. So you would be able to see that your catheter, ablation catheter, is between, let's say, left and right coronary cusp, but it is not going to show you the way that it is showing in this view, that really right under the cusp, that where we talk about endocardial aspect of the LV summit.
So I think one of the best things about this video that you put together is kind of comparing the anatomy on ice with the McAlpine. Okay, this is a beautiful image. I think some even call it the money shot of this whole series. Tell me a little bit more about when you're ablating the LV summit. Okay, what are some of the anatomic pitfalls that you mitigate with ice?
Yeah, for the LV summit, basically, if you're going to use with the ice, you're going to be, when you use the ice, basically, it's going to exactly tell you, there is no doubt that where exactly your ablation catheter, or for that matter, your mapping catheter is. Because there is no doubt that you are, let's say, you can see the left coronary cusp, you can see the, let's say, left main, you can exactly see you're right under the cusp. You can even see the lesion formation, and the way that you're going to see the lesion formation, and also the way that you would see that bubbles are generating. The more bubbles, you know that there is a small chance that you may have a steam pop, so you want to go down on the power or just stop. So it really, not only it mitigates those obstacles, it really helps you to have a much better, much more successful, and a more efficacious as well as safer procedure.
You know, I think you brought up a really good point, which is ice-guided lesions. I think I find it to be exceptionally helpful in the ventricle. You know, do you always use ice to guide your lesions, and does it allow you to kind of maybe be more aggressive, to titrate more power to watch and see?
That is absolutely correct. Yes, not only for this case that was presented here, but for every case that I perform, my ice catheter is always very close to the ablation catheter. So let's say if I'm going to do Afib ablation, my ice catheter is very close to the ablation catheter. If I'm going to do sometime papillary muscle, sometimes I place the ice catheter through the transeptal right by the ablation catheter, so I would be able to see the generation of the lesion formation. That is really helpful to exactly tell you that where you are and what type of lesion you are forming, and if you can just go a little bit more power with no issues.
No, that's great. Now with LV summit ablation, now this was an endocardial LV summit ablation. Now, sometimes, right, you have to go out the AIV, right, to ablate. And I know you are the master of zero fluoro. So I want to put you on the spot and ask you the question of, say you put your catheter way out in the AIV. Have you, I am not, you know, when I do it, I get an angiogram because I'm too chicken. When you approach LV summit ablation from the AIV, do you get an angiogram, or are you able to image on ice?
Definitely. If I'm going to be in the AIV, no question asked, I would always perform an angiogram, because, you know, we are here. Ice is going to facilitate what I want to achieve, what I can do for the best, but I don't want to definitely take any risk. And that is absolute. I don't think that is wise to do. If anywhere, except that, of course, if you're going to do, let's say, left sinus valsalva PVC or right sinus valsalva PVC, you can see the orifice of the left main or right coronary artery, so you know how far you are from it by ice. So I don't do angiogram for those.
Yeah.
But if I'm going to do those area, which is going to be epicardial kind of, and there is no way of me knowing how close I am to the, let's say, LAD or so, you must perform an angiogram.
Okay. Now, in this video, you show an example of using the catheter straight versus looping the catheter, and beautiful images on ice of both. Okay. Are you able to tell me a little bit about the, you know, how do you make the decision to loop it versus not, and what do the different catheter orientations get you?
Excellent. Thank you for that question. So when you make a catheter like a candy cane, when it becomes like a candy cane, oh, how do I do that? Okay, yeah. Like maybe do a candy cane, you want to take a curve off to be able to put some more pressure. If I take the curve off and I see that I'm not putting enough pressure and I'm not having a good lesion, so if I just remove the curve, release the candy cane and just go straight to that area, I believe I would be able to have a better, you know, contact and more force to be able to deliver a better lesion, kind of a deeper lesion.
Yeah.
That's why you can just choose in between. But with that regard, in that, if you're going to do a straight, of course, you won't be able to see, majority of time, you won't be able to go right under the
Yeah.
coronary cast. So that's why you want to have both ways to be able to do the entire area with both, doing the kind of curve candy cane as well as going straight.
And I found sometimes, right, ice helps you because you can see the size of the LVOT and see, will the loop give me the proper reach and proper force? Or, I've had some very, very tiny women who, or tiny patients who can't accommodate the loop, and the straight actually
Sure.
is more helpful. So I wanted to ask you another question, because you alluded to it in the beginning about, imaging this area from the RVOT, right? The LV summit and cusps and whatnot, and then also imaging from the right atrium. Can you compare and contrast those two views and tell me what are the strengths of one versus the other?
Certainly. If you're going to, I would prefer to do for LV summit, for that endocardial aspect of the LV summit, I believe the best area to do it is a little bit going high inside the right atrium, a little bit go forward and closer to the septum, and minimal clock. When you minimal clock, before you start seeing the left atrium and left atrial appendage, when you minimal clock, you would be able to see it. And that way you would be able to see the longitudinal way and right under the cusp. So you would be able to see the cusp opening and closing. So you would be able to see the ablation catheter right under the cusp. If you're going to look at it from the RV or RVOT, majority of time, you would be able to see very nicely the LVOT, or you would be able to see the short axis of the aortic valve, but you won't be able to see that very LV summit under the cusp. So that's why I prefer to use both of them. So I look at that right atrial way to be able to make sure that I'm under the coronary cusp, and then I go to the RVOT or RV and clock it to see the short axis, make sure exactly I'm between the left, let's say, and right coronary cusp where I would like to burn.
Okay, so kind of they both add different things and they complement each other. But you, for the upfront, for imaging the LV ostium right beneath the cusp, you think the right atrial view?
Right atrial is the way to go, I believe, but you always want to make sure that, as I mentioned, several different ways to be able to achieve the same view, or they are going to complement each other definitely.
Okay, and so I want to one final question here. So tell me, what kind of concisely in your own words, what was the greatest value that ICE in this case added to your procedure?
The best value for that was, I believe, was for the patient, because we were able to get rid of that PVC within few seconds, and patients, so it was a safe procedure. It was an efficacious procedure. It makes the procedure, I believe, faster because you can see it. It is in front of you. It reduces the complication rate, as well as, everything, to be honest with you, it is just so hard to summarize it with ICE, because I believe it is something so essential, and it is something so valuable that you see when you use it, and you see this case, as opposed to, trying to look at the RAO image on the X-ray, LAO image to see exactly where you are. This exactly tells you where you are. There is no guessing game there. You exactly know where you are, and you know that location, you're getting a good lesion, and you're taking care of that.
There's a phrase we use in our lab. It's called ICE is truth. It shows you exactly where the catheter is and what's going on inside the heart.
There is no guessing game.
Well, I thank you very much.